Hello, my name is Owuraku Titi-Lartey, and I'm a recently graduated student from Barts. Today I'll be going through a few neurology topics. In particular, I'll be going through neuromuscular disorders, demyelinating diseases, epilepsy, and brain tumors. With regards to neuromuscular disorders, the conditions I'll be going through are disorders of the neuromuscular junction, motor neuron disease, and myopathies. And then a bit more about neuromuscular disorders. They're effectively diseases concerning the motor unit. So, for example, in this image, you can see the motor unit. There's a motor neuron, and then the motor neuron synapses with the muscle fiber at the neuromuscular junction. And so, disorders of the motor neuron can occur in, say, motor neuron disease. And you can have disorders of the neuromuscular junction, as I've mentioned before, so Myasthenia gravis, Lambert Eaton syndrome, and botulism, and then you can have disorders of the actual muscle fiber itself in conditions such as Duchenne's, myotonic dystrophy, and inflammatory myopathy. However, we're going to start off with the neuromuscular junction disorders. So in this image, you can see the presynaptic nerve terminal and the postsynaptic muscle membrane. Disorders concerning either the presynaptic nerve terminal can occur, such as in Lambert Eaton syndrome or in botulism, in which you have an impairment of the release of acetylcholine, the neurotransmitter. And this also mentions the aminoglycoside antibiotics, which can also contribute to an impairment in the release of neurotransmitters. And it's important to note that people suffering from these conditions should not be given aminoglycoside antibiotics for this reason. How all neuromuscular junction disorders can occur due to diseases affecting the postsynaptic membrane, the postsynaptic muscle membrane, such as myasthenia gravis. So starting off with myasthenia gravis, as I've mentioned, this is a disorder in which you have a disease affecting the postsynaptic membrane. You have the production of autoantibodies, so the body mistakes, say, one of its own structures, in particular the acetylcholine receptor or the muscle-specific receptor tyrosine kinase. As a result, you have an impairment of the generation of an action potential in the postsynaptic muscle membrane. Usually, acetylcholine is released from the presynaptic nerve terminal, travels across the synaptic cleft and binds to the acetylcholine receptors, and this leads to the generation of a potential. In order for muscle contraction to occur, a certain threshold has to be met. And if you have a binding of these autoantibodies to the postsynaptic receptors, you have a reduced action potential generation in the postsynaptic membrane. And it tends to be associated with particular conditions. So similar to other autoimmune conditions, they tend to be related. So say pernicious anemia, Graves syndrome, Hashimoto's. Patients who have myasthenia gravis may have a family history of people with other autoimmune conditions, or may have the autoimmune conditions themselves. And then with regards to thymomas, thymoma in particular is associated with myasthenia gravis in young patients. So if, say, you have a young patient who you suspect has myasthenia gravis or has confirmed myasthenia gravis, it's quite important to do investigations for thymoma. So essentially a tumor of the thymus gland. With regards to the clinical presentation of myasthenia gravis, the characteristic feature of myasthenia gravis is muscle fatigue and muscle weakness, which is associated with muscle use, such that if a person was to use a muscle or a muscle group repeatedly, it would begin to fatigue. And this tends to present clinically. So, for example, a person may come into the clinic complaining that they feel quite weak at the end of the day, or they feel quite weak after doing certain activities, such as, say, going to work or so on. And clinically, it can be further subdivided into a sort of progression or a progressive set of stages. So, for example, with class 1, they may only present with ocular features. So I'll discuss these ocular signs and features in more detail. with class 2, they would have mild generalized weakness. Class 3, moderate generalized with mild to moderate ocular bulbar weakness. And so concerning the bulbar muscles, so the muscles related to speech and swallowing as well, class 4 would be when they have severe generalized and ocular bulbar weakness, and then class 5 would be a myasthenic crisis. And I'll go into more detail with regards to what a myasthenic crisis is and how to treat it further along. So with regards to the cranial nerve symptoms, with the ocular involvement, the patient may present with ptosis or ophthalmoplegia. So, for example, in this, the person with ptosis, it may appear that their eyelid is sagging downwards, and they may complain that it's obstructing their vision, or people are saying that they look very tired at the end of the day, and it's actually because they have weakness of the, say, the levator pulpare superioris, which is leading to the ptosis. And then with ophthalmoplegia, the patient may complain that they have double vision, or that they're seeing two things at once, because the weakness of some of the extraocular muscles leads to malalignment of the eyes, and then generation of a double image. They may also complain of blurring of vision because of ophthalmoplegia, because they're unable to focus on images. And so in this image, this is a sign known as Cogan's lid twitch. Essentially, what you do is you tell the patient to look down for a period of time, then you tell them to look up, and then because the muscles which are related to looking down become fatigued, as they look up, their eye overshoots, because the muscles which are related to looking upwards, so for example, the inferior rectus for looking downwards would become fatigued, and then when they look upwards, the superior rectus, which hasn't become fatigued, will overshoot. And essentially, usually during eye movements, antagonistic muscles usually act against each other to prevent that, but because the inferior rectus would be weak when they're looking upwards, after looking downwards, it would overshoot. Another sign which is seen in myasthenia gravis is the curtain sign, where essentially if you were to passively raise one of the eyelids, it would lead to the lowering of the other eyelid. So for example, in this image, you can see this man, so neither of the eyelids are being lifted upwards, and then in the next image, the passive raising of his right eyelid leads to the closing of his left eye, and vice versa on the other side. Another sign which is associated with myasthenia gravis, another cranial nerve sign, is something called the peak sign. So essentially, you tell the patient to, first of all, in this image, you can see that this person has ptosis. So asymmetric ptosis on their right side, it looks as if their eyelid is sagging downwards. And then you tell them to close their eyes very tightly for a period of time. And as I've mentioned, because myasthenia gravis occurs it's because the clinical signs of myasthenia gravis occur when a person has prolonged muscle contraction. They will find it difficult essentially to keep their eyes closed, and it will appear that they're peeking through the closed eyes. And this occurs because of a fatigue of the apicularis oculi muscles. And so patients with myasthenia gravis again may complain of weakness of the jaw muscles. So for example, if they're chewing food, they may find it difficult to chew because of their repeated movements. Weakness of the facial muscles. So for example, in this image, this patient is being told to smile, and because of because of weakness in the muscles of facial expression, there's an asymmetrical facial expression, and furthermore, there's a sort of characteristic sign or appearance associated with myasthenia gravis known as the myasthenic snarl, where essentially when you tell a patient to smile, because of the weakness of the muscles of facial expression, they have this sort of characteristic appearance. Furthermore, because they may have weakness of the bulbar muscles, so as I've mentioned, the muscles associated with speech, swallowing, and so on, they may have a difficulty pronouncing words, or difficulty coordinating the muscles which are associated with speech, which may lead to dysphonic speech and dysphagia again, so they may complain of difficulty swallowing. And then again, difficulty with swallowing, say the secretions inside the mouth and inside the nose may lead to a sort of nasally gargling speech, which is another characteristic feature which is associated with myasthenia gravis. And then with regards to things that you can do to investigate fatigability, say in the clinic, in a patient who may not actually have obvious overt ocular or cranial nerve signs, you can tell the patient to flap their arms. So essentially, similar to say when you're assessing a person's strength of, when you're doing the peripheral nervous system exam, and you want to assess a person's muscular strength, you tell them to put their arms out like a chicken. You can essentially tell them to flap their arms repeatedly like that for about 20 seconds. And you may notice that after 20 seconds, they find it very difficult to do that, and they become a bit fatigued. Another thing you can do is tell them to stamp their feet on the floor, and then again, they may become fatigued. And then lid fatigue is essentially the peak sign. So you tell them to close their eyes for a period of time, and then because of weakness of the orbicularis oculi muscle, they start to open their eyes because of fatigue of the muscles. And then another thing you can do is tell a patient to count down from, say, 50 or 20 down to 0. And then because of the weakness of the muscles associated with articulation and pronunciation of words, they may start to find it very difficult to pronounce words as they reach the lesser numbers. In particular, there are certain things which may exacerbate a person's myasthenia gravis. So it's quite important to ask people about this, such as, were there any scenarios in which you notice that your weakness is especially bad, or if they started any recent medications. So, for example, gentamicin, opiates, beta blockers, lithium and phenytoin are known to exacerbate myasthenia gravis. So again, with regards to the diagnosis of myasthenia gravis, besides the clinical signs and symptoms, there are certain investigations which you can do. So as I've mentioned, myasthenia gravis is related to autoantibodies against the postsynaptic acetylcholine receptor and the muscle-specific kinase receptor. In particular, anti-muscle specific kinase receptor antibodies are associated with patients who present predominantly with bulbar and facial muscle weakness. And then there is also nerve conduction studies. And so because with myasthenia gravis, with repeated actions, they develop fatigue and weakness of the muscles. And by, for example, stimulating the muscle fibers with a high frequency pulse, for example 3 Hz pulse, you will notice that the amplitude of the muscle contraction reduces over time. And so essentially that's what this diagram is showing. So with the first muscle contraction, there's a normal amplitude. However, with repeated muscle contractions, the amplitude reduces. And a characteristic, or one thing that you should look out for in, say, exam questions is a decrement of 15% in the amplitude of the muscle contraction with a 3 Hz pulse. And so the reason why this happens is because you have the depletion of acetylcholine, which leads to reduced postsynaptic receptor stimulation, and as a result, reduced strength of muscle stimulation. Another test which can be done in people who have myasthenia gravis is the tensilon test, or the edrophonium test. So essentially, edrophonium is a short-acting drug. It's given to patients. Usually, you would give a patient 2 milligrams IV, quite slowly, with atropine beforehand, because edrophonium is a muscarinic drug, and if you were to give a person edrophonium without atropine beforehand, they can suffer from quite undesirable cholinergic effects. So you give them atropine beforehand. So you give them edrophonium, and then you observe the patient to see if there's an improvement in the weakness associated with myasthenia gravis. And so, for example, in this image, there is a man suffering from asymmetric facial weakness with ptosis. After being given edrophonium, he looks quite happy. He's able to use both sides of his facial muscles quite well. However, in patients who, when you give them 2 milligrams, if you don't see a response, you may give them 8 milligrams afterwards IV, and so you would usually give a maximum of 10 milligrams total. After giving 8 milligrams, you wouldn't try to do this again because of the potential undesirable side effects of edrophonium. However, in practice, this investigation isn't done very often because it's quite dangerous because of the cholinergic side effects. Furthermore, in patients with ocular myasthenia, they may not actually have a positive result, and you may have a false positive in Lambert Eaton syndrome, and then a patient who you suspect to have myasthenia gravis may actually have Lambert Eaton syndrome. And then, as I've mentioned, thymomas are associated with myasthenia gravis in younger patients. So it's quite important to do a CT chest or MRI chest in order to look for a potential thymoma. So this image is essentially showing a thymoma in the mediastinum. And so with regards to the management of myasthenia gravis, because the condition occurs due to production of autoantibodies against the postsynaptic acetylcholine receptor and muscle-specific kinase receptor, one of the ways that you can treat myasthenia gravis is to give them acetylcholinesterase inhibitors. So for example, pyridostigmine. So essentially, acetylcholinesterase breaks down acetylcholine after it's bound to the postsynaptic receptor, or if it doesn't bind to the postsynaptic receptor, by giving acetylcholinesterase inhibitors. This increases the amount of acetylcholine in the synaptic cleft, and as a result, increases the amount that binds to postsynaptic receptors, helping to increase the strength of muscular contraction. And so, pyridostigmine is the acetylcholinesterase drug, which is typically used in myasthenia gravis. It usually takes about 15 to 30 minutes to start working, and it would last for about 3 to 4 hours. So patients who suffer from myasthenia gravis may need to take it multiple times per day. So say 30 to 60 milligrams 3 times per day, or 4 times a day. And so TD essentially refers to 3 times daily, and QD is 4 times daily. And then the use of the pyridostigmine can be adjusted depending on the patient's lifestyle. So, for example, a person who has particular weakness of the muscles of mastication may use pyridostigmine 15 to 30 minutes before they have a meal, as this will help them with chewing issues or potentially swallowing issues they may have as a result of myasthenia gravis. And then there is also long-acting delayed-release pyridostigmine for patients who have a weakness, who may have weakness throughout the night. And then similar to, say, edrophonium, because pyridostigmine increases acetylcholine, this can lead to cholinergic side effects, which can be quite bad. And then with regards to thymectomy, because thymomas are associated with patients with myasthenia gravis at a young age, it's quite important to investigate for a thymoma, so it can be removed. A thymoma itself isn't necessarily malignant. However, because there is a risk of local tumor spread and the risk of malignant conversion, it's important for the thymoma to be removed. Furthermore, in patients who don't actually have an enlargement of the thymus gland or a thymoma, it's been shown that removal of the thymus gland can help to improve the symptoms associated with myasthenia gravis. In particular, 85% of patients experience an improvement after the removal of the thymus gland, even if there is no thymoma. And then, as I was referring to the cholinergic side effects of edrophonium and pyridostigmine, it's something known as the cholinergic toxidrome. So back to first year physiology, the effects of the muscarinic receptors. So this image shows a person who, and so the reason why it shows insecticide at the bottom left of the image is that organophosphate poisoning, which is an insecticide, can present with cholinergic syndrome. So essentially, a person with the cholinergic toxidrome or cholinergic crisis may complain of excessive sweating, tearing of the eyes, a runny nose. They may be vomiting or have a lot of secretions of saliva inside the mouth. Furthermore, because the muscarinic receptors can cause bradycardia, they may complain of syncope or dizziness as a result of the bradycardia. They may also have a loss of urinary and fecal continence and complain of passing of urine and feces. And a way that the cholinergic crisis can be remembered is the mnemonic, which is sludge. So S for salivation, L for lacrimation, U for urination, D for defecation, G for GI cramping, and then E for emesis. And some people actually refer to the cholinergic toxidrome as sludge syndrome, but it's actually the cholinergic toxidrome. Furthermore, in patients who are, that don't have a good response to, say, acetylcholinesterase inhibitors, immunomodulation therapy can be considered. So, for example, glucocorticoids may be used. For other drugs such as azathioprine, mycophenolate, cyclosporine, and tacrolimus may also be used. With regards to glucocorticoids, so the immunomodulation therapy chosen usually depends on the patient's lifestyle factors, how quick you need a response to the medication, how severe the disease is. With regards to things such as IVIG and plasmapheresis, this is usually used in patients who have a very severe myasthenia gravis, which has a significant impact on their life because the amount of time that it takes for a response to IVIG and plasmapheresis is quite short, whereas, say, glucocorticoids and other immunosuppressants take a prolonged period of time for response. And so, for example, a patient who, say, is the bread is the main source of income in their house may not really have enough time to wait for glucocorticoids or other immunosuppressants, and so they may benefit from plasmapheresis or IVIG instead. Whereas glucocorticoids would be a patient who needs an intermediate term management. So a response within about 1 to 3 months rather than a response within a few weeks. Furthermore, other drugs such as cyclosporine and tacrolimus also give a sort of intermediate response. However, drugs such as azathioprine and mycophenolate usually take many months or up to a year for an actual clinical response. However, they tend to have a much better long-term response compared to, say, glucocorticoids and cyclosporine and tacrolimus. And then a bit more with regards to the therapy of with glucocorticoids. This is something which is quite consistent with glucocorticoids amongst other conditions. Usually, you don't want to. If you were to give a patient glucocorticoids, you would start off with a low dose. So, say for example, 15 to 25 milligrams per day, and then you would gradually increase the dose until you have a clinical improvement or maximum dose of, say, 50 to 60 milligrams is reached. And this is because of the side effects of glucocorticoids. They can be quite bad. You can have things such as steroid-induced osteoporosis, hypertension, acne, thinning of the skin. It can have psychological side effects. Patients may complain of depression or psychosis, weight gain, and so on. And so for this reason, if you were to give a patient glucocorticoids, it's important to give them osteoporosis prophylaxis as well, in the form of, say, calcium and vitamin D. And then a bit more information with regards to the immunosuppressants. So usually, say, azathioprine is typically used because it has a good safety profile. It may be used alongside glucocorticoids as well. So, for example, if a patient needs intermediate response, you would start them on glucocorticoids and azathioprine, and then once they've been stable for, say, a year, you would start to taper down the glucocorticoids and leave them on just azathioprine. And so, plasmapheresis, essentially what plasmapheresis is where you have the a patient is usually connected to a machine into a large vein, where their blood is taken from them, containing both the plasma and their red blood cells, and passed through a machine. And then the plasma is exchanged with say, a donor plasma. And this helps to get rid of the autoantibodies, which are binding to the acetylcholine receptor and the muscle-specific kinase receptor. However, the red blood cells aren't exchanged, so essentially you're removing the plasma containing the autoantibodies whilst not removing the red blood cells. And then IVIG, essentially the idea behind it is that people, the IVI, people who the IVIG is actually taken from is usually from a large donor source and then compiled together. It may contain antibodies which bind to the autoantibodies against acetylcholine. So by giving a person IVIG, this helps to neutralize the autoantibodies against acetylcholine. However, some people may have an sort of like essentially an autoimmune response against the IVIG. So this isn't always the only way to treat a person with myasthenia gravis. So as I've mentioned earlier on, patients with myasthenia gravis may suffer from something known as a myasthenic crisis. So essentially, a myasthenic crisis is an exacerbation of the weakness associated with myasthenia gravis, which puts a patient's life at risk. If they have a weakness of the respiratory muscles, it can lead to difficulty breathing, a reduction in the forced vital capacity. In particular, the criteria for myasthenia gravis is a forced vital capacity below 1 liter. If they have a negative inspiratory force of 20 centimeters of water or less, and if they have a need for ventilatory support and or endotracheal intubation and ventilation. And so in these patients, it's important to give them immediate and emergency treatment, as they can deteriorate quite quickly and die quite quickly. So they would be given IV neostigmine or atropine and prednisolone. And it's also important to note that a myasthenic crisis can also occur in patients that are overdosing on the acetylcholinesterase inhibitors such as pyridostigmine. In particular, patients who are on more than 960 milligrams of pyridostigmine per day are at a particular risk of developing a myasthenic crisis. So moving on to the other neuromuscular junction related condition. So Lambert Eaton syndrome. So in this diagram you can see that it's a condition which affects the presynaptic membrane. You have the development of autoantibodies against the presynaptic P or Q voltage-gated calcium channels. And so as a result, so usually normal physiology is that you have the an action potential, which travels down an axon and then reaches the synaptic knob. This leads to activation of the voltage-gated calcium channels, and this leads to the entry of calcium into the synaptic knob, and then the entry of calcium into the synaptic knob causes the activation of the presynaptic vesicles, which then fuse with the presynaptic membrane, leading to the release of acetylcholine. In patients with Lambert Eaton syndrome, the production of autoantibodies against the presynaptic P/Q voltage-gated calcium channels leads to an interruption in the system, and as a result, reduced release of acetylcholine into the synaptic cleft. And so, similar to, say, myasthenia gravis, this leads to weakness of muscle contraction, as you have less acetylcholine binding to the postsynaptic acetylcholine receptors. So Lambert Eaton syndrome in particular is associated with malignancies. Particular malignancies include small cell bronchial carcinoma, breast cancers, and ovarian cancers. In some patients, Lambert Eaton syndrome is just an autoimmune condition. However, in the paraneoplastic form, which is associated with malignancy, it's in particular associated with autoantibodies against SOX1. However, this isn't the cause of the disease. The disease is due to the production of autoantibodies against the presynaptic P/Q voltage-gated calcium channels. And so, similar to myasthenia gravis, the main presenting complaint in patients with Lambert Eaton syndrome is muscle weakness. However, Lambert Eaton syndrome has a tendency to cause proximal muscle weakness, especially of the extremities, so of the legs. So especially in particular hip girdle or shoulder girdle weakness. And so patients with Lambert Eaton syndrome may present with difficulties going up the stairs, difficulty combing their hair or picking things out of the cupboards because they find it difficult to lift their arms above their head, and so on. Another sign that patients with Lambert Eaton syndrome may complain of is difficulty getting out of chairs because of weakness of the muscles of the hip, in particular the pelvic girdle muscles. However, dissimilar to myasthenia gravis, after a brief exercise or repeated muscle contraction, they have an improvement in the muscle weakness. And this is also related to the characteristic findings in the diagnosis of myasthenia of Lambert Eaton syndrome. Patients with Lambert Eaton syndrome also characteristically present with reduced reflexes and autonomic symptoms, so they may complain that their mouth is quite dry, or they have difficulty seeing things, or they may find it difficult standing up because of irregular control of the blood pressure, which is all related to the autonomic symptoms related to Lambert Eaton syndrome. And then in Lambert Eaton syndrome, they may also complain of ocular bulbar weakness. In particular, the cranial nerve symptoms are seen in about 70% of patients with Lambert Eaton syndrome. And then the autonomic signs are quite frequently seen in Lambert Eaton syndrome as well, in up to about 80 to 96% of patients. And so the diagnosis of Lambert Eaton syndrome, similar to myasthenia gravis again, can be through the detection of serum antibodies against the voltage-gated calcium channels. So high titers of the voltage-gated calcium channel antibodies are associated with Lambert Eaton syndrome in up to about 90% of patients. However, high titers of voltage-gated calcium channel antibodies are also found in about 20 to 40% of patients who don't have Lambert Eaton syndrome. So the presence of autoantibodies against the voltage-gated calcium channels isn't definitively diagnostic of Lambert Eaton syndrome. Further investigations you can do include nerve conduction studies. So patients with Lambert Eaton syndrome will present with an improvement or an increase in the muscle potential after repeated exercise or repeated nerve stimulation. So that's one of the ways that you can differentiate myasthenia gravis from Lambert Eaton syndrome in patients who have very similar signs and symptoms, or if you find it very difficult to differentiate between these two conditions. And in particular, with regards to the electrodiagnostic testing, patients with Lambert Eaton syndrome will show a decremental response with low rates of repetitive nerve stimulation. However, if you have high rates of repetitive nerve stimulation, they have an incremental response. And because Lambert Eaton syndrome is associated with malignancy, it's quite important to do an investigation for any potential malignancy associated with Lambert Eaton syndrome. So say a CT or MRI scan of the chest in order to look for a lung cancer, or a PET scan of, or a CT or MRI of the abdomen and so on to look for, say, intra-abdominal cancers. If the CT or MRI doesn't show anything, you may do a PET scan in order to see if there are any, if that shows anything. And usually, patients who have Lambert Eaton syndrome but don't show up with any sort of cancers on CT or MRI scans would have repeated investigations over a period of time, just to make sure that at the moment that the initial CT or MRI scan was done, the cancer was undetectable, and it may have become detectable later on, which would then facilitate the treatment of the cancer. And so the management of Lambert Eaton syndrome. In patients who have Lambert Eaton syndrome, which is related to lung cancers or a malignancy anywhere, you would have either chemotherapy, radiotherapy, or surgery. And that's quite a consistent theme with regards to malignancies. Usually patients may have chemotherapy, radiotherapy, or surgery depending on the stage of the malignancy, depending on their functional status and so on. And the treatment of the cancer, which is causing the paraneoplastic syndrome, leads to symptomatic improvement in Lambert Eaton syndrome. Furthermore, acetylcholinesterase inhibitors such as predostigmine can be given, and this works along to the same mechanism as described for myasthenia gravis. And there's also a drug known as a 3,4-diaminopyridine, or 3,4-DAP. And so this essentially promotes the release of acetylcholine by prolonging the opening of the voltage-gated calcium channels. And patients who are refractory to the symptomatic treatment of acetylcholine, Lambert Eaton syndrome, using pyridostigmine or 3,4-DAP, may be indicated for immunotherapy. However, it's quite important to note that because a proportion of patients with Lambert Eaton syndrome may have undiagnosed cancers, the immunotherapy may cause worsening of an undetected cancer. And in patients who do receive immunotherapy for Lambert Eaton syndrome, it can be steroids or immunosuppressants such as azathioprine, or it may be IV or IVIG or plasmapheresis, similar to myasthenia gravis. And so now moving on to botulism. So botulism again is another condition of the neuromuscular junction. The Botox toxin is produced by a bacterium known as C. botulinum. It prevents the release of presynaptic acetylcholine in a similar mechanism to Lambert Eaton syndrome by inhibiting the presynaptic voltage-gated calcium channels. So in particular, the Botox toxin is actually one of the deadliest toxins known to man. Has a very high potency and lethality, and the lethal dose needed to kill, say, 50% of people exposed to it is approximately 1 nanogram to 3 nanograms per kilogram of body weight. So C. botulinum is actually quite commonly found in soil and water sediments. There are different genotypes from A to F. However, the toxic types are A, B, E, and F. And usually when C. botulinum is ingested, it doesn't cause disease, as the production of the toxin isn't in significant enough quantities to cause the disease, although the bacterium is killed by the stomach acid. However, there are particular food sources which are associated with C. botulinum. These can be things such as improperly stored honey, or honey which has gone off, or improperly stored canned foods, improperly stored jarred foods as well. So for example, in this image you can see jarred pickles and chilies and so on. And this is a potential source of C. botulinum if they're not properly stored. And in patients who present with the features of botulinum that I'm going to describe earlier on, it's quite important to take note of any, if they've consumed any dodgy food recently, or food which was off, or food which was not properly stored. Botulism is more common in infants than it is in adults. About 70% of botulism which occurs in practice occurs in infants, whereas in adults it's much more common for them to... So with infants, usually they develop botulism because of colonization of the GI tract by the C. botulinum, because their immune systems aren't as properly developed as adults. Their ability to, say, fight against these C. botulinum is impaired. And so C. botulinum may colonize the GI tract and start to produce the toxin, causing the presentation of botulism in children. In adults, botulism can occur because of the consumption of improperly stored foods, or canned foods, or contaminated wounds. And it's quite important to note that the presentation of these different sources tends to be somewhat different. And there may be different preceding features associated with these different causes of botulism. So with the clinical presentation of botulism, the clinical features which are usually seen first would be cranial nerve palsies, bilateral. In particular, and this would progress over a period of about 12 to 36 hours after the onset of symptoms. And one of the ways to remember the presentation of botulism is bilateral dysphagia, dysarthria, diplopia, and dysphonia. And this is essentially the 4 Ds which is associated with botulism. In patients who have botulism because of foodborne sources, They may complain of symptoms of food poisoning beforehand. They may be vomiting, they may have diarrhea or nausea, abdominal pain or abdominal cramps. They may have a fever and so on. And so it's quite important to take a thorough history from a patient who presents with these sorts of features in order to ask them if they've had any, say, diarrhea or abdominal pain, or if they've eaten any foods which was not properly stored before the onset of symptoms. So the flaccid paralysis usually starts off with the cranial nerves, and then it starts to progress downwards. So this is described characteristically as a descending flaccid paralysis, and it may also come to affect the muscles of respiratory control, leading to respiratory compromisation. Patients with botulism may also suffer from autonomic dysfunction, such that they may have a dry mouth, constipation, postural hypertension, and they may also feel quite cold because of the impaired autonomic control. And patients with botulism characteristically present with a loss of their reflexes as well. Because there are other conditions which can present somewhat similarly, with sudden onset weakness, such as, say, Myasthenia gravis or Guillain-Barré syndrome, or cerebrovascular accidents, it's quite important to differentiate between these conditions. And then furthermore, patients who suffer from botulism because of wounds, they may have, say, a dirty wound. Maybe they injured themselves in the garden, they fell down, and they developed a wound which came into contact with soil. So, as I've mentioned, C. botulinum is commonly found in soil. So this may be a potential etiology for wound botulism. However, the incubation time is usually a bit longer, usually about 5 to 15 days from the time of the introduction of the C. botulinum into the wound. In infants, because infants, it's a bit harder to distinguish the features of botulism in infants. It can be somewhat non-specific. The mother may present with their child who's suffering from constipation or weakness, a weak cry, difficulty feeding or drooling of the mouth. In these sorts of situations, it's usually better to refer a child who's presenting with acute onset weakness or drooling or a weak cry to the emergency department, just because it may not just be botulism. There are many other conditions which can present in a similar way. And in particular, a floppy baby or a baby with a very low muscle tone with global hypertonia is also indicates that they may have botulism. And this also further indicates the need for urgent ventilation, as there's a risk of respiratory compromise. And so with the diagnosis of botulism, the neurologic manifestations of descending paralysis and clear sensorium, so they don't have any sensory signs, which is associated with a potential source, so say C. botulinum, which has been cultured from a wound or cultured from the patient's stool, a documentation of the presence of the Botox toxin in the serum, wound, stool, or inside contaminated food, or if the patient presents with clinical signs which are associated with food poisoning. Usually, if a person has botulism and they have a confirmed source, this would be sufficient for diagnosis. However, in cases where it's not it's a bit harder to determine what the actual cause is, you may do nerve conduction studies, and similar to the other conditions, you would see a reduction in muscle potential with normal sensory conduction. And so with the management of botulism, because it can cause respiratory compromise and difficulty breathing, it's quite important that these patients are urgently transferred to the intensive care unit for aggressive respiratory monitoring and therapy, where, say, the respiratory rate, the oxygen saturations, the blood pressure, and so on will be regularly measured every hour, or say every half hour, in order to note for any deterioration in the patient's respiratory function. Because these patients may have difficulty swallowing, it's quite important that they still stay well nourished, and so they require adequate nutrition whilst inside the ITU. It's been shown that something known as guanidine can help to increase the release of acetylcholine from the presynaptic nerve terminals, and this can be useful in mild cases of botulism. However, in severe cases of botulism where the patient has severe respiratory compromise, it may not be as useful. And something which is very important is the Botox antitoxin. So this is an equine-derived antitoxin, and it's usually combined in the same mixture, and it's against the A, B, and E forms. However, there isn't an antitoxin against the F form. So this should be given as soon as a clinical diagnosis is made. However, it doesn't inactivate the toxin, which is already bound to the nerve terminals, such that if a person presents with a botulism, say, 5 days after the onset of symptoms, this may not really help because the toxin is already bound to the presynaptic channels, and the usual recommended dose is about 10 millimeters of the antitoxin. Usually you don't want to give them any more than this because this is an equine, so a horse-derived antitoxin, and it's associated with hypersensitivity reactions such as urticaria and serum sickness. And then if the patient suffers from botulism because of a wound infection, it's quite important that the wound is debrided in order to get rid of any C. botulinum which may have colonized the wound. And if patients are given antibiotics in order to clear the wound, it's quite important. It's even more important that they're given the antitoxin, even if this is after a period of time of the presentation of symptoms, because the antibiotics will cause the lysis of the bacterium, and this can lead to the release of massive amounts of antitoxin into the system. And so essentially giving the antitoxin in order to prevent an even worse episode of botulism. And as I've mentioned earlier on, aminoglycoside antibiotics are associated with neuromuscular junction blockade. So you shouldn't give aminoglycoside antibiotics to patients who have wound botulism. And so this is an image which is essentially giving an overview of the neuromuscular junction disorders, and it can be quite useful for your revision, which is why I put it in here. Okay, so moving on to motor neuron disease, otherwise known as Lou Gehrig's disease. So Lou Gehrig was an American baseballer who suffered from motor neuron disease. And so motor neuron disease it occurs due to the death of motor neurons, and this can be lower motor neurons or upper motor neurons. With regards to the lower motor neurons, this concerns the motor neurons in the anterior horn cells and the spinal cords, and their analogues in the brainstem. The upper motor neurons would be the motor neurons found in the corticospinal tract, and the motor neurons found in the fifth layer of the motor cortex. The pathology would usually show characteristic shrinking of the motor neurons with the accumulation of intracellular lipofuscin. And so the etiology of motor neuron disease, the majority is acquired, so about 90% is acquired. However, 10% of cases have a familial aspect. The most common mutations associated with a familial motor neuron disease would be the C9orf72 mutation. However, there are other mutations associated with motor neuron disease, such as the SOD1 mutation, mutations in TDP43, FUS, which is the fused in sarcoma mutation, and the VCP mutation. And so the clinical presentation of motor neuron disease, it tends to vary by quite a bit, and it depends on whether or not the motor neurons involved are the upper or lower motor neurons. But in, say, in an exam question, the typical sort of things you should look out for are asymmetric weakness with wasting of the extremities, or a mixture of both muscle spasticity and muscle flaccid paralysis. And in particular, the weak wasting of the extremities is seen in about 75% of patients. The bulbar or pseudobulbar features, so features concerning the muscles of swallowing, of chewing, and so on, are seen in about 25% of patients. Motor neuron disease is also associated with something known as frontal temporal dementia, which may be seen in about 3 to 5% of patients with motor neuron disease. And it's important to note that because motor neuron disease affects, unsurprisingly, the motor neurons, they won't have any sensory signs. There are no blood signs and no ocular signs as well. So here's a table summarizing the difference between upper motor neuron signs and lower motor neuron signs. So a person who has motor neuron disease primarily affecting, say, the upper motor neurons will complain primarily of spasticity, hyperreflexia, whereas a person with a motor neuron disease affecting primarily the lower motor neurons will complain of reduced muscle tone and flaccidity of muscles. And so this is a table which can be useful for your revision and helping with understanding the difference between upper and lower motor neuron lesions. And so the most common form of motor neuron disease would be amyotrophic lateral sclerosis. And so this involves both the upper and lower motor neurons. Typically it starts off with just one limb, but gradually spreads to affect other limbs and the muscles of the trunk. And so this diagram essentially shows how there's a combination of asymmetric mixed upper and lower motor neurons. Just one side has upper motor neuron and then one other side has lower motor neuron. And so it can cause progressive focal weakness and wasting of the muscles. And these patients may also complain of muscle fasciculations, and this occurs because of the death of the motor neurons subsequently leads to the generation of abnormally large motor units. So essentially you have muscle fibers which become denervated, and then the remaining motor units then have to branch off to supply these muscle fibers. And so you have motor neurons which are supplying multiple muscle fibers, which is quite inefficient. And because it affects both the upper and lower motor neurons, they have a combination of upper and lower motor neuron size. And so this image is essentially showing a characteristic feature which is associated with amyotrophic lateral sclerosis or motor neuron disease in general, which is a sort of a sagging of the head because of the weakness of the muscles which keep the neck in position. And then another form of motor neuron disease is progressive muscular atrophy, and so this is found in 10% of patients with accounts for 10% of patients with motor neuron disease. They present primarily with pure lower motor neuron weakness, pure lower motor neuron signs. So this would include weakness, wasting of muscles and fasciculations. And then similar to amyotrophic lateral sclerosis, it tends to start off in one limb and then gradually spreads to involve other muscle groups, typically in adjacent muscle segments. And it tends to affect the distal muscle groups before it affects the proximal muscle groups. And then another subcategory of motor neuron disease is progressive bulbar palsy. And so progressive bulbar palsy it presents with a combination of corticobulbar degeneration and the involvement of lower cranial nerve motor nuclei involvement. And so as such, you have a degeneration of the corticobulbar supply to cranial nerves 5, 7, 10, and 11 and 12, with sparing of cranial nerves 3, 4, and 6. And so this presents with a weakness of chewing because of cranial nerve 5, an expressionless face because of weakness of cranial nerve 7, and an exaggerated jaw jerk reflex, which would be related to cranial nerve 5. On stimulation of the gag reflex tends to be brisk, and this is related to the spasticity of the muscles related to the gag reflex. The patient may have abnormal speech, which is very drawled out or monotonous. They may complain of difficulty swallowing fluids, chewing things, regurgitation of food, and so on. And they may also complain of difficulty moving and manipulating the tongue. And in particular, one of the things that you look out for in patients with progressive bulbar palsy is a folded tongue appearance when you tell them to stick out their tongue. And so primary lateral sclerosis is another subcategory of motor neuron disease. It's quite rare and accounts for 1 to 2% of patients with a motor neuron disease. It primarily affects the upper motor neurons and causes slowly progressive tetraparesis and pseudobulbar palsy. And so because it affects the upper motor neurons, it causes spastic weakness of the limbs, so they have increased muscle tones. Typically, the patient's initial presentation or initial complaint may be spastic dysarthria or dysphagia. And the reason why it occurs is due to the loss of the large pyramidal cells, which are found in the precentral gyrus, along with degeneration of corticospinal and cortical bulbar projections in the spinal cord and brainstem. And so, with regards to the diagnosis of motor neuron disease, patients with the history and examinations of patients with motor neuron disease is quite important, as this tends to be somewhat characteristic. Creatine kinase levels tend to be raised in about 2 to 3% of patients. However, this is not diagnostic, and there are other conditions in which you may have raised serum creatine kinase levels. Similar to other conditions, electrodiagnostic testing can be used. This shows a pattern of active denervation, chronic denervation, or fasciculation, and in particular for the diagnosis of amyotrophic lateral sclerosis, you may see the evidence of active denervation, and so this is characterized by fibrillation potentials in at least 3 of cranial, cervical, thoracic, or lumbosacral regions, and in the limbs, at least 2 different muscles belonging to different nerve roots need to be affected for the electrodiagnostic diagnosis of amyotrophic lateral sclerosis. So MRI is also done sometimes, and this is used to this is indicated in patients who have an abnormal presentation of motor neuron disease, as the signs and symptoms of motor neuron disease may be somewhat similar to other conditions, and you would want to do an MRI to rule out other conditions such as brain tumors or, say, multiple sclerosis. Furthermore, an MRI of the lumbosacral region or the cervical spinal cord region may be done, as patients who are suffering from, say, degenerative disease of the spine may also complain of increased muscle tone or spastic paralysis because of upper motor neuron damage or lower motor neuron damage if it affects the nerve roots. So it's important to do MRIs to rule out the differentials. And so the treatment of motor neuron disease, there is no treatment which works to stop the underlying pathological process. However, there is a drug known as riluzole, and so 100 milligrams per day has been shown to produce a modest lengthening of survival of the disease. And it's thought that this works by reducing excitotoxicity through the reduction of the release of glutamate and helping to reduce the loss of motor neurons. However, there are also side effects associated with the riluzole, such as nausea, dizziness, and weight loss. The primary treatment of motor neuron disease is helping to support the patient. Patients who have, say, swallowing difficulties or chewing difficulties may require nutritional support. If they're still able to swallow, they may have nutritional supplement drinks, or something called a powder that is added to water to increase the consistency of water, so that it becomes much more of a gel sort of substance and is easier to swallow. And patients who have severe difficulty swallowing or severe chewing difficulties, who are, say, on palliative care or near the end of their life, gastrostomy may be considered. And so essentially a tube is inserted into the stomach transcutaneously in order to deliver nutrition through that route instead. Patients with motor neuron disease sometimes suffer from depression, anxiety, and severe psychological problems. These patients require counseling to understand the disease in order to come to an acceptance of the disease and so on. Furthermore, physiotherapy and walking aids may be considered in patients who have difficulty mobilizing. And so physiotherapy, in order to aid with any motor difficulties they may have and any weakness they may have, and then walking aids such as walking sticks and so on, or chair lifts and handrails inside the house, which would be provided by occupational therapy as well. Because motor neuron disease can affect the respiratory muscles, these patients may require long-term ventilatory support, such as mobile ventilation or home ventilation. And near the end of their life, they may be put on long-term ventilation, which may be via tracheostomy through the neck. And so moving on to the myopathy conditions. So there's Duchenne's muscular dystrophy and myotonic dystrophy, and these would be the inherited or genetic conditions. And then there's inflammatory myopathy, which includes dermatomyositis, polymyositis, and inclusion body myopathy as well. So starting off with Duchenne's muscular dystrophy. So Duchenne's is an X-linked condition. It occurs due to a mutation in the dystrophic gene, which is found on the X chromosome, because it's X-linked, so X-linked recessive, and it occurs due to a frame-shift mutation, and is found in about 1 out of 3,500 male births. And so this diagram essentially shows the regions which are typically affected by Duchenne's muscular dystrophy. It typically causes a proximal limb girdle weakness, and so the patients with muscular dystrophy will typically present with a difficulty getting out of the chair or lifting things above the head. And so because it's a genetic condition, it tends to present quite early on. And so the primary presentation or concern that mothers may have is that their child has difficulty walking. The child isn't walking at the same time that, say, other children have started to walk, or the other siblings started to walk. They may have abnormal walking patterns as well, such as tiptoe walking. And it tends to become somewhat apparent between about 3 to 5 years, as there are some children who have delayed walking but don't have Duchenne's muscular dystrophy, and it may be difficult to differentiate between these patients. And so, as I've mentioned, and as this diagram shows, it primarily causes a limb girdle weakness pattern, so the shoulders and the hips. And so the patients with Duchenne's will have particular difficulty getting out of chairs or walking up the stairs or lifting things above their head. And as a result, the child may learn to walk on their tiptoes. And there's something in particular, a particular sign associated with Duchenne's muscular dystrophy, known as the Gowers test. So on attempting to rise from the ground, the child essentially has to climb up their own body, and this occurs due to pelvic muscle weakness. And so this is another thing that you should look out for with examination papers. So a child who's suffering from delayed motor development, and then the mother or the clinician notices the child was lying on the floor and had to sort of climb up themselves in order to get up. And so Duchenne's is also sometimes associated with weakness of the extraocular muscles, and may present with complex ophthalmoplegia, and it tends to be associated with cardiomyopathy and respiratory failure as well. And so Duchenne's muscular dystrophy tends to have a sort of stepwise presentation. So early on, the child may have difficulty playing or running or jumping, and then as time goes on, because of the disease process, they may have the development of contractures, and in particular contractions of the muscles of the calf or the iliotibial band. And this tends to lead to a characteristic sort of lordotic posture, which is shown in this image, so the excessive lumbar lordosis. They also tend to have calf hypertrophy, and it's not because of the accumulation of muscle, it's actually the accumulation of fat due to the replacement of the muscle fibers with fats and the death of muscle fibers. And then as time goes on, the child may need braces or a wheelchair in order to mobilize because of the muscle weakness and the severity of the muscular contractures. the contractures may become fixed both because of the disease process and because of the impaired mobilization. So people who are in wheelchairs for a prolonged period of time sometimes develop muscular contractures because of reduced muscle use. And then as time goes on, weakness of the respiratory muscles leads to recurrent lung infections and aspiration. And this is typically the course that takes place without treatment or physiotherapy. And without treatment, the typical age of death is around, say, 16 to 18 years. So it's so as I've mentioned, the Gowers test, children who say are lying on the floor won't be able to stand up properly and have to sort of climb up themselves. And so this image shows as the child tries to get up, they have to use their own knees to stabilize themselves and then gradually climb up themselves. And then furthermore, this image shows the excessive lumbar lordosis associated with muscle contractures and so on. And so with the diagnosis of Duchenne's muscular dystrophy, Duchenne's muscular dystrophy tends to be associated with very high levels of creatine kinase, sometimes up to 100 or 200 times the normal levels. And so this is another thing that you should look out for with exam papers, actually. So a child who has delayed motor development, and then say creatine kinase levels are taken and they're excessively high, this indicates a child who may have a Duchenne's muscular dystrophy. EMG, or so electromyography, so nerve conduction studies are done. It shows normal nerve conduction, and this is because there is no issue with the motor neuron or with the neuromuscular junction. However, there is an issue with the muscle fiber itself, and so you will see myopathic motor units on muscle stimulation. And so with muscle biopsy, there is a sort of characteristic appearance of the muscle biopsy. So this image, you can see there's a mixture of normal muscle fibers and sort of fatty replacement. So this is muscle fiber which has been replaced with fat, and then normal muscle fibers. And then on top of that, you have a sort of irregular distribution of the size and shape of the muscle fibers. And this, again, is related to the disease process. Furthermore, genetic testing in order to identify the mutation associated with Duchenne's muscular dystrophy can be done in order to diagnose Duchenne's. And so the primary way that Duchenne's muscular dystrophy is treated is physiotherapy and occupational therapy. And so this involves, say, daily stretching, daily exercises, helping to prevent the development of contractures. And so essentially stretching the muscles in order to prevent the contractures from developing, helping to maintain muscular strength through exercises. Occupational therapy would include the changing of, say, for example, putting things in place in the house to help with mobilization, such as handrails or chair lifts, or, say, orthotics to help with difficulties walking. And so this is the primary way that Duchenne's muscular dystrophy is treated, as the other treatment modalities only help to reduce the progression of disease, such as, say, glucocorticoids. And it's been shown that the administration of 0.75 milligrams per kilogram per day can help to slow the progression of disease for up to about 3 years. Because Duchenne's muscular dystrophy is associated with cardiomyopathy, some patients with Duchenne's may develop congestive heart failure. In these patients, treatment of the congestive heart failure is needed. And as a result of the heart failure, they may also develop pulmonary hypertension. And in the context of Duchenne's muscular dystrophy, if they have weakness of the muscles of respiration, which is compounded with heart failure and pulmonary hypertension, this can cause, and then on top of that, they may also have kyphoscoliosis, or spine deformities, which can then again compound on the respiratory difficulties. So patients with, say, weakness of the respiratory muscles, heart failure, pulmonary hypertension, kyphoscoliosis, may need significant respiratory support. So, say, mobile ventilation, long-term ventilation in the form of, say, a tracheostomy and so on. And so, because the main cause of death in patients with muscular dystrophy is respiratory failure and lung infections. And so moving on, to myotonic dystrophy, there are two main types, type 1 and type 2. They're both autosomal dominant conditions. Myotonic dystrophy type 1 occurs due to a trinucleotide repeat expansion in a non-coding sequence in the DMPK gene, which is found in chromosome 19. So similar to other trinucleotide expansion conditions such as Huntington's, you normally have a normal length of the gene, which is 5 to 37. However, in myotonic dystrophy type 1, the pathological length would be about 50 to 1,000. And the prevalence is about 5 out of 100,000 people. Myotonic dystrophy type 2 occurs due to a quadruplet repeat expansion in the zinc finger protein 9 found on chromosome 3. And so the typical presentation of myotonic dystrophy type 1, because it's a genetic condition, it can present from quite early on. In children, it may present with a floppy baby syndrome, so a child with very low muscle tone. And so as this image shows, it tends to affect the distal muscles, so the muscles of hand grip and hand manipulation, and the muscles of the calf and feet. However, it may also affect the muscles around the neck, the intercostal muscles, and the diaphragm, and the muscles of facial expression. As such, some of the presenting features in patients with myotonic dystrophy, which may not have been initially diagnosed, may be delayed skeletal muscle relaxation. So they may complain about holding, say, a screwdriver or a pen, or holding onto the door. They find it very hard to relax their muscles, and there's, as I mentioned, delayed muscle relaxation. The disease process may also cause wasting of the muscles in the neck, such as the sternocleidomastoid, or muscles in the face and head, such as the temporalis muscles and masseters. And as such, it can lead to ptosis and facial drooping and facial asymmetry, so which is shown in this image. So this person has ptosis along with muscle weakness. They may also complain of drooling because of weakness of the facial muscles. And then this is something which is known as hatchet facies. Weakness of the temporalis muscle leads to this characteristic appearance. And then because it's a genetic condition, it has multi-systemic features. It can cause cataracts. In particular, myotonic dystrophy presents with a shield-shaped cataracts. It can cause smooth muscle disorders, so it can cause issues with the muscles associated with urination, the GI tract. They may complain of diarrhea or constipation, of abdominal discomfort because of the smooth muscle issues. It can also affect the heart and cause cardiomyopathy. It's associated with diabetes as well, and tends to be associated with hypogonadism. And as a result, patients with myotonic dystrophy may have gynecomastia or abnormally small testicles. With regards to the type 1 and type 2 myotonic dystrophy, it's quite important to differentiate between the two. So as I've mentioned, the features which are associated with type 1 myotonic dystrophy is that it tends to affect the distal muscles. So as shown in this image, it affects the feet, the calves, the hands, and the wrists. It tends to be associated with GI symptoms, so gastrointestinal problems. It can cause reduced life expectancy and tends to present between about 0 to 50 years of age. And young children who present with myotonic dystrophy may have reduced muscle tone, learning difficulties, and facial dysplasia. Whereas with type 2 myotonic dystrophy, it tends to present primarily with proximal weakness. So it will present with girdle weaknesses, hip and shoulder girdle weaknesses. It tends to present primarily with atrophy of the proximal muscles and hypertrophy of the calves. People with type 2 myotonic dystrophy may also have a tremor, and it tends to present after the age of 15 with a mean age of about 40 years. However, there are sort of key features which are associated with both type 1 and type 2 myotonic dystrophy, and so these would be, as shown in this image, myotonia, muscle weakness and atrophy, cataracts, cardiac arrhythmias, cardiomyopathy, cognitive dysfunction, hypersomnia, hyper-GGT, insulin-resistant testicular atrophy, frontal balding, hypogammaglobulinemia, and muscular pains. And so the diagnosis of myotonic dystrophy. Myotonic dystrophy can cause a mild elevation in creatine kinase, not as much as, say, Duchenne's muscular dystrophy. Patients with myotonic dystrophy will have normal nerve conduction studies, so this may be done to rule out other conditions which present in a similar way. However, when you do the nerve conduction studies will show that the motor neurons conduct impulses normally. However, when you do an EMG, so when you measure the potentials generated in the muscles, not the conduction of impulses down the motor neurons, you will see myotonic potentials. So this image shows an example of myotonic potentials. On the generation of a muscle contraction, you have difficulty with muscle relaxation, so you have this prolonged potential, and this is related to the reason why patients with myotonic dystrophy have a difficulty relaxing, because they have these prolonged muscle potentials. And this tends to be more obvious in patients with type 1 myotonic dystrophy. A muscle biopsy may also be done in patients with myotonic dystrophy, and the biopsy would typically show increased internal nuclei and the atrophy of muscles, and tends to selectively involve type 1 muscular fibers. And because myotonic dystrophy is a genetic condition, genetic testing can be done to diagnose myotonic dystrophy. And so with regards to the management of myotonic dystrophy, the primary way that is treated is with physical activity. And so in order to help reduce the muscle atrophy and maintain muscular strength, it's been shown that aerobic exercise, in particular, say stationary bicycle exercising, has been shown to improve muscle fitness and muscular strength. Medication can be used, and so this includes medications such as phenytoin and meloxicam, and these help to reduce the myotonia, so to reduce the prolonged muscular contraction, so that, say, for example, when they're holding on to things, their muscle contraction isn't prolonged for a long period of time. In patients with a cardiac disease, say treatment of the cardiac disease is considered, so treatment of the heart failure, or treatment of patients with dilated cardiomyopathy who have, say, unexplained syncope or advanced conduction deficit, so this would be second or third degree heart blocks, may be considered for a cardiac pacemaker, as they are at an increased risk of sudden cardiac death. And then, similar to other conditions, occupational therapy may be considered. So this would include, say, walking sticks or foot orthoses, or specialized shoes to help patients move about. And then the treatment of the associated conditions, such as hypogonadism. They may be considered for androgen replacement therapy. In patients with diabetes, they need the control of the diabetes, so lifestyle and risk modifications, so improvement of their diet. They should stop smoking, antihypertensive if they have hypertension, statins, and if needed, they may also be considered for anti-diabetic drugs. And furthermore, patients who are suffering from cataracts will also need cataracts removal and insertion of an intraocular lens. And so onto the inflammatory myopathies. This concerns polymyositis, dermatomyositis, and inclusion body myositis. So starting off with polymyositis. Polymyositis, as I mentioned, is an inflammatory myopathy. It's mainly seen in adults, rarely seen in children, and is characterized by the features of polymyositis without involvement of the skin. It tends to affect the proximal muscles, so the hips and the shoulders, so limb girdle weakness again, and tends to be symmetrical. And then, so similar to other limb girdle conditions, the patient will complain they have difficulties going up the stairs, difficulty getting out of their chair, difficulty combing their hair, or picking things out of the cupboard, for example. It affects both the upper and lower extremities, so both the shoulders and the hip girdle. They may also have bulbar sinus dysphagia, muscular pain, so myalgia, because of the inflammation of the muscle, and systemic symptoms such as polyarthritis. The investigation of polymyositis includes EMGs, and so they will have myopathic motor units with increased exertional activity. So similar to the other conditions affecting the muscle, they will have abnormal impulses on muscle contraction. However, the conduction through the motor neurons will be normal. Polymyositis tends to be associated with raised levels of creatine kinase because of the death of the muscle fibers. And then furthermore, there's a characteristic appearance associated with biopsies. And so you see this sort of perimysial and endomysial inflammatory infiltrate. So you have white blood cells around the muscle fibers because of the inflammatory response associated with polymyositis. And then with dermatomyositis, it tends to be seen in both adults and children, unlike polymyositis, which is just in adults. Similar to polymyositis, they tend to have a proximal weakness, so the shoulders and the hips, and so again they'll have the typical presentation of a proximal limb girdle weakness. However, there is a characteristic rash associated with dermatomyositis, and in some patients this actually precedes the onset of the myopathy. On the face, there's the heliotrope rash. So this tends to be around the eyes and is associated with periorbital edema and swelling of the eyes. And it's in exam questions it may be described as a purplish or violaceous hue over the eyes. And then over the knuckles they may have Gottron's papules. And again, this is a key feature to look out for in exams. Say for example, a patient who has muscle pain and weakness, difficulty doing things around the house, and they've noticed an abnormal rash on their eyes or their knuckles. And so dermatomyositis is also further associated with calcinosis, so the deposition of calcium in the skin, cardiomyopathy, and interstitial lung disease. So dermatomyositis, typically after the presentation of dermatomyositis, 20% of patients may also present with features of an underlying malignancy. So the investigation of dermatomyositis, similar to polymyositis, is associated with raised creatine kinase, along with perivesicular atrophy on biopsy of the muscular fibers. Because of the association with underlying malignancies, it's important to do an investigation for potential malignancies. So this may be a CT or MRI or chest X-ray to look for lung cancers. In a woman, you may do a mammogram. Full blood counts, because patients who have malignancies may have anemia of chronic disease or anemia because of blood loss, because of, say, colon cancer. A urine analysis in patients who have bladder cancer, and a colonoscopy in patients who you suspect may have cancer due to colon cancer. Dermatomyositis is also associated with raised anti-nuclear antibodies and anti-JO1 antibodies. And so this is another important thing with regards to exams. We say a patient who presents with muscular pains has a battery of tests done to them, which shows that they're positive for anti-JO1 antibodies, and so this would indicate that they may have dermatomyositis. And so with regards to the treatment of polymyositis and dermatomyositis, usually they would be started on glucocorticoids. This may be 1 to 1.5 milligrams per kilogram per day. They're usually put on alternate day dosing, so they would have glucocorticoids on one day, and then the next day they wouldn't have it, and then the day afterwards they would take it again. And then once these symptoms are adequately controlled, so reduction of the muscle weakness and muscle pain, you would consider tapering the dose because of the side effects of glucocorticoids, which I mentioned earlier on. And one of the ways that the response to glucocorticoids can be assessed is by sequential creatine kinase measurements. So you would expect your levels of creatine kinase to reduce as you increase the dose when you start the glucocorticoids. And it's important that patients who are put on long-term glucocorticoids have osteoporosis prevention or protection, so in the form of vitamin D and calcium. In patients who have a poor response to glucocorticoids, are contraindicated or have significant side effects, steroid-sparing therapy may be considered. And so similar to, as I mentioned earlier on, if they have very severe symptoms and they need a response within a shorter period of time, IVIG or plasmapheresis may be considered. And then with long-term therapy, azathioprine and methotrexate may be considered. And so inclusion body myositis. Inclusion body myositis is the most common inflammatory myopathy found in patients over the age of 50. It tends to affect the thighs, in particular the quadriceps, and causes weakness and atrophy of the distal muscles. So the quadriceps can affect the wrists as well, and the muscles inside the calves. In particular, it tends to affect the foot extensors and the deep finger flexors, and so they may complain of difficulty holding onto things or writing because of the weakness of the finger flexors. They may also complain of particular pain inside the quadriceps when walking, issues with balance and falling over because of the weakness of the quadricep muscles as well. And in about 60% of patients, dysphagia may also be seen. On investigation, similar to the other inflammatory myopathies, raised levels of creatine kinase may be seen. And then again, similar to the other inflammatory myopathies, myopathic muscle motor units will be seen. So conduction through the motor neurons is normal. However, the generation of muscle of action potentials in the motor units is abnormal. And then on biopsy, you would see inflammation, which is characterized by endomysial infiltrates. So this image shows the infiltrate of white blood cells around the muscle fibers. However, one of the differentiating features between dermatomyositis and polymyositis versus inclusion body myositis is the presence of inclusion bodies which stain positive for amyloid. And so this is a table, which helps to show the difference between the different inflammatory myopathies, which can be useful for your revision.